here is your question and your timer has started. Okay, Bell has gone. Today I have something different. So if you have read and understood, kindly begin your examination station.
Yes, I am ready.
Yes.
Good morning. I am Mr. Al-Ghaziri, one of surgical Dr. Zahir. Can I confirm your name and age, please, ma'am?
I'm Samantha, 55 years old.
Nice to meet you. I will wash my hands. Today I'm going to examine your hands. It will include look, feel, and movement, and ask you to do some special movement, and I will do some test. Do you agree with this?
Yes.
Do you have any pain at the moment?
No.
Okay, I will try to be gentle in examination. If you feel any pain, let me know.
Okay.
I will examine the patient by exposure, by exposing elbow joint and shoulder, and will examine the patient on below. Firstly, I will start by general look. Will include can you put your hands in front of you at the dorsum?
Yes.
Then I will ask the patient to turn the hand to search for any scars, swelling, or any nodules. Then I will ask the patient, can you bend your elbow and raise your hand, please, to see the elbow, ulnar and the radial side of the forearm. Then I will ask the patient, now I will feel your hands. If you feel any pain, let me know. Then I will start by feeling the temperature of both hands from distal to proximal, comparison with both sides. Then I will feel the pulse in both hands. Then after that, I will start by I will detect any tenderness. Will start by the ulnar radial side of the arm of the forearm, styloid process of both ulna and radia, scaphoid, then metacarpopharyngeal joint by squeezing both hands, joint by joint, and I will also feel any wasting of hypothenar and senar muscles, and any palmar aponeurosis for to exclude any debutine contracture. After that, this is the feel. Then we will start some movement for the patient after tenderness and the pulse and so on. Movement. I will ask the patient to make a fist and spell your finger. Then after that, I will ask the patient to do a prayer sign and inverted prayer sign. Then I will ask the patient to do. I will do the same movement passively by taking the hand of the patient, moving flexion extension, supination and pronation, with feeling any click on by the other hand left side. Then I will ask the patient will feel the sensation. I will start by feeling a sensation at the tip of the sternum, and will ask the patient if he feel. Let me know by yes. Then I will start to assess three nerves at the hypothenar senar, at the senar median nerve, hypothenar ulnar nerve, and the first dorsal web space for radial nerve. After that, I will go for another movement in the form of squeeze the finger, stretch the hand and the finger, and will ask the patient to let me to push it for extension finger and extension of the wrist. Then after that, I will examine for median nerve in form of counting the finger, then counting the finger for opponent's polishes, then abduction of the spelling of the finger. Don't let me to push it for abduction of the finger. Then ask the patient to turn the hand with pointing with the thumb to the ceiling for extension. After that, I will put a card board test between the index and the thumb, and withdraw the board to test the adduction of the thumb. Then I will go through the flexor digitorum profundus superficialis testing by put the patient in extension, flex, suspend the metacarpopharyngeal, and ask the patient to bend each finger to test the proximal interpharyngeal joint movement for superficialis, and fix proximal to test the distal interpharyngeal joint. Then we'll ask the patient to will tap on the palmar side of the wrist to do what's called Tinel test, and we'll ask the patient, if you feel any numbness or needles in your finger, let me know. And then I ask the patient to do inverted prayer sign of flexion of the wrist to Fallon test. If you experience any tingling or numbness of your finger, let me know. This what I do for examination. I finished my examination. I thank the patient. You can cover your hands now. To complete my examination, I will do a cervical spine examination and do complete neurovascular examination of the hand. Okay.
Can you present your case now? You still have 40 seconds. Yeah. Still okay.
Today I examined a 50-year-old man who is presented with right hand pain. On examination, there is no apparent deformity, just there is numbness at the radial 3.5 finger on the palmar aspect, and weak muscles, loop muscles of median nerve supply, lumbricals, flexor and abductor, and opponent's pollicis nervous. Otherwise, normal movement with positive Tinel signs and Fallon signs. So my top differential diagnosis is carpal tunnel syndrome, but I will consider also cervical disc problem or diabetic neuropathy, as the patient is diabetic patient. This is my case.
Okay. Can you please tell me what is your provisional diagnosis?
Carpal tunnel syndrome with median nerve entrapment.
Okay. How do you plan to manage this patient?
Yes, as regards the management, will include further diagnosis, investigation in form of X-ray cervical spine. Also, I will do nerve conduction test and electromyography, but I will consider also MRI to detect any space occupying lesion of the wrist, and X-ray wrist, AB and lateral. And regarding diabetes, I will detect blood glucose investigation, and the neurotonics and vitamin B12 blood hematinics.
Okay,
and as regard the management,
yes,
upon which nerve conduction study, if the patient is mild to moderate nerve entrapment, I will start by pain relief non-steroidal anti-inflammatory or paracetamol. Also, I will splintage for at least 3 weeks at bedtime. Also consider the local injection of steroid in the retinaculum. If the patient is severe disease or failure of conservative management, I will go through for surgical release of the carpal tunnel.
Okay. Can you name few risk factors which are associated with higher risk factors for carpal tunnel syndrome?
As regards the gender, female patient, high BMI, obese, square wrist, amyloidosis, renal dialysis, acromegaly, thyroid disease, diabetes, rheumatoid arthritis, tenosynovitis, space occupying lesion, or previous fracture of the wrist.
Yes, and even white face. Good. Okay, we still have few seconds left. 14 seconds left. Okay. Right. Thank you.
Thank you,
anyone wants to give feedback? It was good, Dr. Mohammed. It was very good. But
thank you, ma'am. Thank you.
You could have added no bell went. Today it's different. Sorry. Close. Okay.
Did he mention the power grip and pincer grip and the precision grip?
Those he missed, and
I missed this. Yes,
and
I missed
even
precision.
in the inspection, he had to look at the dorsum as well, like not just the hand, even he mentioned palm of the hand. in detail, but I don't think he mentioned about the dorsum of the hand and then the nails, everything like
Nails, yeah.
what
Oh, and the
more?
palpation for
I mentioned the dorsum of the hand, then the palm of the hand.
Okay, but
and
did you
But I
mention
missed the pincer grip and the hand grip and the
yeah,
precision. Yes, I missed this.
and the deformities, which could be like you rule out the swan neck deformity and all those in the and the nail changes. I don't know.
Yes, any
Did you-
deformity? I mentioned any deformity or nodules like
okay.
herpes nodules.
Yeah,
Yes.
yeah, good.
Yes.
and also palpation for psoriatic nodules in the elbow.
Yes, this is the palpation of ulnar and radial, and
Ulnar
asking the patient to bend the elbow and raise the hand.
Okay.
I mentioned that.
Okay, and you did mention the neurological examination as well. Okay, good. Rest, I think he covered everything. It was very good.
Thank you, ma'am.
Temperature again in palpation, you I think
I mentioned temperature.
yes,
Yes,
you mentioned
from distal
yes.
to proximal. Yes, and
Yes,
the
very good.
comparison bilateral. Yes.
So it's becoming good and good every day. So it's really good.
Thank you, ma'am. Thank you.
Thank you. The timer, and here is your question.
Okay.
It's still 30 seconds left, so you can read. Okay, so if you have read and understood, considering it clinical examination station, kindly begin your examination.
Yep. Okay. First, I will wash my hands and then introduce myself. Hello, I am
Yes.
Dr. Muhammad, the treating doctor of today. May I confirm your name and age, please?
Yes, Tim, 19 years old.
Nice to meet you, Mr. Ken. Today I have been asked to examine your foot and ankle joints. This will include looking, feeling, and doing some special that. Are you okay with that?
Yes.
Do you feel comfortable in the place?
Yes.
Okay. Do you have any pain at the moment?
Negligible, I can tolerate.
Okay. Now I will ask. Now I will ask him to expose here. Please, can you expose your foot and your knee joint till above your knee?
Okay.
Okay, thank you.
Yes.
Then I will ask him and help him. Can you please walk 4 steps for me?
Okay.
Do you need any help?
I'll see how much I can do. Yes. Next.
Okay, thank you. And I will ask come back again, and then I will look at his ankle and foot if there is any skin scars, if there is any change in erythema, if there is any swelling or asymmetry or deformity.
Yes.
And if there is a walking aid beside him, also if there is any abnormality in the gait, it may look like antalgic gait. Then I will ask the patient to sit down and then sit down on the couch and then start palpation.
Yes.
And now I will feel your feet. Please, if you feel any pain at the moment, tell me to stop. Okay.
Yes.
I will start by the normal side, the left side, by quick and by I will start by temperature, by examining temperature and comparing the pulse with the other legs, and then start the quick examinations of the normal side, of the left side, by palpation. By palpations and of the knee joint, ankle of the ankle joint, and of the ankle joint, and the calcaneus and metatarsal and the toes. Then I will start the right leg and be gentle, right ankle and be gentle. I will start by palpations from the joint, from distal to proximal, toes, then metatarsal, then metatarsals, then calcaneus and ankle and medial and lateral malleolus, and the feeling of above for any tenderness in the lateral, in the fibula, in the above fibula, for Musini fracture. Then I will assess the pulses and compare between both sides, dorsalis pedis and posterior tibial.
Then movements.
Okay.
Yes.
Then I will start assessing the movement, plantar and dorsal flexions, active and passively, and eversion and inversion only passively. And then I will ask the patient to sit in the couch with his knee out and doing a squeeze test for the Achilles tendon. Normally there should be plantar flexions if it is intact, and then I will do a special test, anterior withdrawal test for assessing the anterior talofibular ligament.
Yes.
And the valgus and varus withdrawal test to assess the deltoid ligament, valgus and varus stress test to assess the deltoid ligament and calcaneofibular ligament.
Any other test?
No, Simon and
yes, it was not anyway. Okay, next.
Then I will I will ask. That's all. I will help the patients.
How do you perform the Simon test?
Simon?
Yes. When do you do it? To assess what?
For the Achilles tendon.
Yes. To assess the rupture. Yes, intactness. How do you do that? How do you perform that? What do you instruct the patient?
By asking the patient wheeling on the couch or in a chair, and his leg is out, and then squeeze the.
How should the foot be in the plantar flexions?
Plantar flexion.
Yes, yes. Okay, good. Can you present your case now, please?
Today I have been examined Mr. Kane. He is 19 years old basketball player. He is brought to the emergency for complaining of severe pain in his right foot. By inspections, there is an antalgic gait. There is no walking aid. There is no walking aid with the patient. There is no skin erythema or scars. There is no swelling. And no asymmetrical signs, and no asymmetry and no deformity scenes. By feeling, there is equal temperatures. There is tenderness in the right angle, in the lateral malleolus of the right ankle joint, and by assessing the movement, there is limited movement. Especially in inversion of his right ankle, and on doing special tests, there is the varus stress test is positive, indicating indicating calcaneofibular ligament injury.
Okay, good. So what are your provisional diagnosis?
My differential diagnosis is calcaneofibular ligament injury, fracture lateral malleolus, fracture lateral cuneiform, fracture cuboid.
Good. So how do you plan to manage this patient?
Yes, I will manage these patients by rest and ice and elevation of his leg and the back slab until edema subside. And if there is any fracture in the X, and do X-ray for the ankle anterior, posterior, and lateral, and the mortise view. If there is any fracture, I should go for a cast after the edema subsides.
Okay. Would there be any role of asking MRI to be done for this patient?
Yes, MRI should do MRI to exclude any ligamentous injury.
Okay, good. And if X-ray shows that there is undisplaced fracture of fibula with swelling of the ankle, what would you do?
Yes, I will manage for below knee cast after the edema subsides.
Okay, with the rest and ice and elevation. All right.
And rest and ice.
Okay, we still had some seconds left. All right, okay, good. Yes, now well went. One second left. All right, good, Dr. Hamdi, it is very good. So at the end, you thank the patient and you ask the patient to
Yes,
dress up and you wash your hands.
And to complete my examination, I would like to do examination of the right of the knee and a full neurological examination of
Very
his
good.
lower limb.
Yes, good. This you forgot to tell, but now you remember. So it's good. Thank you. Anyone wants to give feedback? What are the special tests?
Yes, ma'am, Miss.
Yes.
She
please.
he missed anterior jaw test and the talar
He
test.
told anterior jaw test. And what was the other test?
Talar test.
Yes, talar test.
Talar
For
tilt
two,
is
He
talar
was
tilt
mentioning it with some other name, but
varus
then,
and
yes,
valgus test.
those you do for the knee
Okay.
examination. Okay, good. So this is something you have to
Otherwise it
correct
was
yourself.
good.
Otherwise it was good. And you kept your time, you mentioned everything, but then you have to be careful what special test that you're mentioning. Right. Good. Thank you.
In should I do examination of the normal limb, or there will not be
Yes,
any time?
yes, at the same time. Even you have to do it quickly, but then you have to do both.
Okay.
Otherwise, that's why we have two limbs. How are you comparing it? You have to look. If you mention that injured limb is swelled, then how are you, or what are you comparing it with? So you have to examine both.
Okay.
Yes. Good. Started your timer, and here is your question. Okay, so if you have read and understood, considering it critical care scenario, kindly tell me how do you plan to manage this patient?
Yes, as regards this patient, is he has what what we say DIC, disseminated endovascular coagulopathy.
Yes.
But he is a patient as a critical care surgical patient, but we will make sure that the ABCD, but we will focus on the specific pathology in form
Yes.
of DIC. This patient will be firstly to include or liaise with hematology consultant. After
Yes.
that, we will manage in form of correction of anemia, platelet, fresh frozen plasma, and the cryoprecipitate, which is deficient for his investigation.
Okay. All right. How would you plan, since patient has lost 4 liters of blood, how would you decide, and patient is hypothermic as well, so how would you decide how much blood should be transfused to the patient?
Can you restate the question again?
Yes,
About
please.
hypothermia? What is the
Yes,
cause
patient has ruptured abdominal aortic aneurysm. Patient has lost 4 liters of blood, and patient is hypothermic as well. So how would you decide how much fluid replacement or blood replacement should be given to the patient?
According to the hematocrit value and according to the pulse blood pressure, cardiac index parameter in form of pulse, blood pressure, capillary fill, urine output, and the mental status, and the patient is under general anesthesia, so mental status is not.
Yes, but how would you
sufficient.
decide how much blood should be given to
Yes.
the patient? Because here, yes, patient was given 3 units of blood. Is that enough, or is it? Yes. How could you comment on this?
According to 3 units of blood.
Yes, please.
We will evaluate the patient according to a shock grade.
Shock grade. Very good. Yes. Now you are telling me,
yes.
right? Yes.
Yes, shock grade. If the patient is grade 1 less than 750 to 1.5 liter is grade 2, grade 3 from 1.5 and liter to 3 liter and more, according to the shock grade.
Okay.
See,
so in this case, patient is categorized in which grade of shock?
grade 4.
Grade 4. Okay. So yes, can you tell me how would you decide if the blood transfusion has been massive?
If the patient, if the replacement of blood volume is more than 50% within
Yes.
12,
Yes.
within 12 or 24 hours, replacement of 50% of the blood volume.
Okay. Can you please mention few complications that can result because of massive blood transfusion?
Yes, as regard blood transfusion, fluid overload, metabolic, metabolic disturbance in form of hyperkalemia and hypocalcemia.
Yes.
Also hypothermia, coagulopathy,
Yes.
deficient platelet, transfusion-related acute lung injury in form of ARDS.
Yes.
And also of the hemolytic reaction, febrile non-hemolytic reaction,
Yes.
and the hypothermia.
Very good. Can you, you just mentioned 3 products that you decided or you thought that they are beneficial for the patient. Why would you choose the platelet transfusion? Can you give some indications?
Indication of platelet transfusion is blood loss, less than thrombocytopenia is less than 50, and platelet dysfunction or consumption in form of DIC, disseminated endovascular coagulopathy, or cardiopulmonary bypass due to consumption of the platelet.
All right. What is the shelf life of platelets?
5 days.
At room temperature. Okay. Can you tell me, please, how platelets should be transfused?
Firstly, put in the shaker before transfusion. Then can you pass this question, please?
Okay. Can you please tell me how this patient temperature is 37 Celsius. So can you please tell me how a normal person can generate heat to warm itself? What is the mechanism? Yes, what is the mechanism? How would you how would a normal person generate heat to warm itself?
How to warm this patient?
No, not how to warm this patient. How a normal person like you and me will warm ourselves. What is the mechanism?
Through
okay,
through. Okay. the mechanism of temperature loss.
Okay. Can you please tell me, in this patient,
Yes.
what would you do to stop bleeding or stop blood loss from happening?
Yes, as regards this patient, I will start by hypotensive technique of anesthesia.
Okay.
Control the bleeding through compression or diathermy.
Yes.
Also by red cell saver.
Okay.
And the control of visible bleeding through ligation or compression or
Yes.
control by diaphragm. Okay.
Okay. Can you please tell me, since patient had aortic abdominal aneurysm rupture, so can you please mention some complications which can occur because of this rupture?
Yes, hypovolemic shock.
Okay.
Due to rupture of the abdominal aortic aneurysm, as regard maybe renal failure, sexual dysfunction, spinal ischemia.
All right. Actually, there is rupture and then, okay, thrombosis or embolism or fistulation, etc. So what is the, if you can classify, what are the immediate complications, post-op complications, or later? So if you can tell some.
Immediate complication as hemorrhage and renal failure, late maybe spinal ischemia and sexual dysfunction, and the clonic ischemia.
Okay. How should aortic abdominal rupture should be managed?
According to abdominal aortic aneurysm, we will start by ABC as he is critical patient, but as regards the specific management in form of AVAR technique, abdominal aortic aneurysm.
Is that IVR technique that you're mentioning, is it ideal for all types of aortic abdominal aneurysms?
No, an infrarenal.
Infrarenal. Yes.
Yes.
And
another technique?
Yes, open abdominal or that one, because for infrarenal.
Endovascular stent.
Stent. Yes.
Yes. Yes.
Okay, time has ended, but Dr. Mohammed, some of the questions I'm not really happy, I can say, as per your answers. Maybe you can elaborate more, because when you were telling me even complications of aortic abdominal aneurysm, so I did not get to hear all the complications that could result, even the management. You can maybe start telling me, okay, if you can tell me, how would you assess a patient who has abdominal aortic aneurysm? So how would you assess, or how would you evaluate, or how would you monitor that patient? How frequently are you going to examine or follow up the patient?
No, I can't know this question. Didn't read before.
Yes, you should read, because we'll do again. We'll do this session again. Okay, you read, and then we will, in next 1 day or 2 day or 3 days, we will do again. This is very important, and 2-3 stations can be covered just with this knowledge, because this is hypothermia, and then this is DIC, another station which is DIC. Okay, that can also be covered with this one. Then hemorrhagic shock. If a station comes on hemorrhagic shock, it can also be covered with this one. And then this is again, then you see blood transfusions can be covered with this. So abdominal aortic aneurysm can be covered with this. So 4-5 stations can be covered just with this little knowledge. Right.
Yes.
Please, ma'am, how is the EVAR is the same as the stent?
Sorry?
EVAR is the same as the vascular stent, or it is different?
Yes, yes. What is EVAR? Just tell me, abbreviation stands for what?
EVAR is endovascular repair.
Yes.
Abdominal
so for repair. Which kind of aneurysm you'll go for this? For post-renal, I don't think it's ideal, because space is less.
What?
For what kind of? It's not ideal for what kind of aneurysms? Can you tell me?
EVAR for
Yes,
I don't-
it's ideal for what type of aneurysm? Abdominal aneurysm.
infrarenal.
Okay. And for what type of aneurysms it is not ideal? You can't go for IVR for all the patients. You have to choose which ones it's contraindicated.
Yes. What's it's contraindicated in which type?
Yes, for which type of aneurysm it is contraindicated, please.
I don't know. I'm asking.
You should read because you got yesterday's day as well, so you have exam in 1 month.
Okay.
If I tell you everything, you can go back and listen to my previous recordings and then you find the answer there. But I want you to find the answer by reading it because then you'll remember it until the exam.
Okay.
For not all type of aortic abdominal aneurysm, either is ideal. For some, you have to still do the open surgery. And then you have to tell me about the aneurysm as well. What are the types? How would you classify the types of aneurysm? When would you go for which aneurysm? And then for which management? Which management is ideal for which type of aneurysm? And then how would you follow up the case? Is there any difference if you follow up a female patient or a male patient? So you have to tell me what is the difference if a male patient has abdominal aortic aneurysm and if a female patient has abdominal aortic aneurysm. Is there any difference? Who is more susceptible to rupture? Who is more susceptible? It's the male. Females, yes, females rarely have rupture aortic aneurysm. Rarely. See, so it's not. They don't. They can, but it's rare. So it's the male. And then how? What is the size? Every year, how frequently are you going to follow up the patient? Just say 70 years old patient patient had accident and you did the MRI or you did the X-ray and you find out, okay, or you did the fast scan, you find out, okay, patient has aortic aneurysm. What should your decision be? How frequently are you going to call the patient? What is the size? Every year, how big it will become? When would you decide, okay, now aneurysm is big enough. If we will not operate on the patient, aneurysm can rupture.
I guess, ma'am, 5 centimeter.
That is the maximum, yes.
Yes, this
But
is
then you have to decide how it doesn't grow this big overnight, it takes time. Every year, how much big it will grow and what will be the neck of the aneurysm. And there are many, like you have to read, please. We'll do this session once more.
okay, ma'am.
Thank you. Yes, I'm starting the timer and here is your question. Here is your question. Okay. you have read and understood, considering it critical care scenario station, kindly please tell me how would you define or how would you measure core body temperature?
Yes, I can measure for the body temperature through either axillary or oral or rectal or
Yes.
tympanic membrane.
Okay, what is the normal core body temperature?
36 degrees Celsius.
Yes, less than. Okay, can you please tell me what might be the causes of hypothermia?
Causes?
Yes, please. What are the causes of hypothermia? When a patient can have hypothermia?
The causes is either if he in a major surgery or
Very good.
massive blood or
Massive blood loss,
transfusions.
yes. Blood loss and transfusion as well. Yes, and please.
Transfusion. And also if there is a preoperative hypothermia less than 36, and
Okay, and cold environment, like the case.
And if the patient taking cold anesthetic agents.
Yes.
during
In the cold
operation.
environment, like this patient jumped in the river. Okay,
Yes.
can you please tell me if you don't get to manage the patient on time? So what are the complications that can occur because of hypothermia?
There is many complications regarding the cardiovascular. There may be arrhythmia and cardiomyopathy and arrhythmia and increase prolonged QR interval.
Decreased cardiac output, yes.
Decreased cardiac output regarding neurological, there may be confusions and disturbed conscious level. Regarding renal functions, there will be decreased renal flow and the glomerular filtration rate, and regarding the gastrointestinal, there will be less motility in GIT and paralytic ileus. And
okay, good. Can you please tell me what are the factors or what is the mechanism behind hypothermia, how it occurs?
Yes, the loss of temperatures by evaporations by evaporation from the body of the patients and by radiation inside the theater, and due to the loss of shivering response by the anesthetic agents and the decreased relaxations of the muscle, and also inhibitions of the hypothalamic reflex, leading to decreased heat production, and the cooling effect of the anesthetic agent.
All right, good. Considering this patient has body temperature of 26 Celsius, kindly take me from here. How would you manage this patient? Considering the lactic acid acidosis and potassium level and everything, how would you manage this patient?
Yes, I will manage this patient according to the critical care of surgical inpatient protocol.
Yes.
I will, by maintaining a patent airway and proper breathing and adequate circulations, then I will go for the specifically for the patients for the temperature. I will use space blanket and intravenous warm fluid for the patients.
Good.
Use the space blanket or woolen blanket, which is also called the bear hugger. I collect the metabolic acidosis by intravenous bicarbonate, and also correct hyperkalemia by giving intravenous calcium glucate 10%, as a cardiac, which has a cardiac protective.
Yes.
Yes, and also giving the patient 5 units of insulin with 15% dextrose to decrease the potassium level, and
Yes.
stop the if the if the patient is taking any potassium sparing diuretic, I should stop it.
Okay, good.
And
What?
then
Yes.
reevaluate the patients by measuring his temperature and doing blood levels of
How
and
frequently would you be measuring patients' vitals and everything?
yeah?
How frequently?
Frequently?
Yes, how frequently are you going to measure patients' vitals and patients' urine output and fluid?
Yes,
intake?
by putting if the patient by detecting urine output, and if the patient is still unconscious, I will put a urine catheter to detect urine output. I also measure the core body temperature, as I called, by rectal or axillary or oral, and do ABG and potassium and lactic acid levels.
Yes, but how frequently will you be doing it? After every 10 minutes or every 1 hour, or how, please?
Temperature?
Everything, yes.
Temperature is temperature is regularly every 1 hour, and
Okay.
the other and for the electrolytes and every 12 hours.
Okay. Can you please tell me, would you ask for any inotropes for this patient?
Yes, if the patient developed complication of hypothermia,
Yes.
if he has manifestations of cardiac of decreased cardiac output, like pale extremities, or decrease or high or tachycardia,
Yes.
I should give him inotropes.
Yes. How would you decide
And
which one to give?
which type of inotropes?
Yes, please.
No, bus.
Okay. Is there any other way that you can suggest for this patient, which is more modern and more innovative, and it can help patient restore its body temperature more quickly?
Other measures?
Yes, any other new measure?
Yes, I should. The patient should be kept in the theater in the core temperatures 21 degree. The patient avoid prolonged fasting, and the patient shouldn't be if the patient is going to the if the patient needs he here is need doesn't need the surgery, use a space blanket and
Yes.
and
But
do
is there, yes, any other method that comes in your mind? Time has ended. We're just discussing.
other methods like
Anyone else? Yes, no response to fluid challenge, then
no response for
to fluid challenge.
to flow the challenge.
Yes.
If no response to flow the challenge,
Yes, what would you do?
no response.
Started the timer, and here is your question. Okay, so if you have read and understood, let me put a okay, so if you have read and understood, considering age, surgical anatomy station, can you please tell me what is this bone that you're looking at right now? Can you identify the bone? You can have help. All everyone can help,
Yes.
Dr. Imon.
Okay. Mm. Is it the Petrus?
Okay, I'll make it easy for you. Please tell me what
Yes,
are the
ma'am.
boundaries of the middle ear?
Okay, ma'am. The boundaries of the middle ear, the roof, which is formed by the tegment tympani
Yes,
and which separates the tympanic cavity.
yes, from
The floor from the mm,
what is MCF?
and is I forgot it.
You can get help.
MCF.
Ask Dr.
Yes.
Mama, Dr. Hamdi, and they should help you. Okay,
The floor
floor,
is
yes.
formed by the thin bone, which separates the tympanic cavity from the superior bulb of the internal jugular vein.
Very good.
The
Yes.
anterior wall is the thin bone which separates the tympanic cavity from the internal carotid artery, and where there is two openings, which one is the auditory tube and the another one is tensor tympani.
Yes.
The posterior wall, which is adduced to the mastoid antrum superiorly,
Yes.
and the pyramid is inferiorly. The
Yes.
lateral wall, which is tympanic membrane, and the medial wall is the lateral wall of the inner ear.
Okay, good. All right. So if you can just look at these and then tell me what is this 8, which is colored here?
Is it the internal carotid artery, ma'am?
Okay, good. And what is this 18 over here?
18 is, ma'am, pass identified.
Okay, and what is this 24?
Is it the middle cerebral artery, ma'am?
We'll discuss at the end. Okay, and here,
Okay.
if you look at this on the right hand side, what is 2? What is 12? Okay.
This is completely.
Yes, it's from Macmillan. What is 13?
Is this
13?
stapedius?
Okay. What is 17?
Can
Can
identify,
you?
ma'am.
Okay. All right. What is this 21?
In the stylet process.
Yes. Okay. Is there any relation? Is it related to any structures or anything? Is there
Yes, it
any?
is attached with the styloglossal stapedius muscles.
Yes. Okay.
Stylophragmus.
Can you please tell me if there is an infection in the ear, how does it spread to the brain?
Okay, the infections usually occur in the middle ear,
Yes.
and it causes direct erosions of the tegment tympani, which enter into the mastoid ear cells and causing mastoiditis.
Okay. What are the symptoms with which patient presents?
Usually the patient presents with the, when it attacks the brain, it presents with the meningitis, fever, neck stiffness, and
Okay.
photophobia.
Yes. All right. Okay. Can you please tell me what are the relations of middle ear? Can you tell me the medial wall? Is it related to what? It's not the same as the boundaries, but it's the relations.
Relations
Of the middle ear.
middle ear with the nasopharynx through the eustachian tube.
It's medial wall, lateral wall, anterior wall, and the floor and the roof. They get separated with some structures.
The middle is
Okay,
there.
if infection spreads from the middle ear to the middle cranial fossa, so which lobe of the brain will be affected?
Middle cranial fossa is temporal lobe.
Yes, yes, good.
Yes.
All right, very good. Okay, so the temporal lobe is responsible for what?
Temporal lobe is responsible. Temporal lobe contains, ma'am, the Broca's area,
Okay,
and there is mm, uh, mm,
okay. Can you please tell me what is neuroblastoma?
neuroblastoma.
Yes.
It is a one kind of tumor of nerve cells.
What type of tumor?
Neuroblastoma. It is a childhood tumor.
Okay. Involves what? Okay, can you please tell me the tumors of the middle ear, of the ear? Or if you can, yes, okay, take the whole ear and then tell me, please. How would you classify?
So
Are they all benign or they are cancerous? as well?
acoustic neuroma.
Yes.
Acoustic neuroma,
No,
which occurs the damage to the vestibulocochlear nerve, and
And
pass, ma'am, no idea about the tumor.
okay,
in
can
the
you
brain.
look at this small picture and tell if you can recognize 13 and 9?
These are the ossicles of the ear.
Yes. How the sound is conducted? Can you tell me?
The sound is conducted by the vibration of the tympanic membrane, which causes, which is maintained by the stapedius muscles, which maintain the tympanic membrane's density, and then it converts into the bony conduction. That's how the sounds conduct.
Okay, thank you.